Hello, everyone. Let everyone get settled after our short break. I hope you're enjoying your morning. I have the distinct pleasure of introducing our next session, which is a featured showcase of our innovation winners from the ACFP's Family Medicine Innovation Forum, which we co-presented with AMA ACT last October. It was a great day, featuring 12 innovative solutions happening right here in Alberta, and today's presenters were our top winners from that showcase. Each presenter will have 10 minutes to share their innovation, followed by a Q&A period for all three presenters. A quick reminder that the Q&A feature is accessible in the attendee hub for those of you at home, and if you're here, you can either ask a question at one of the stationary mics or submit your question in the event app. So we'll have Dr. Shani Kara representing CARMi, Georgina Gaudet from the Bashaw Clinic, and Dr. Charles Wong from HomeFree Homecare. So we'll start with Charles, then Georgina, and then Shani. Welcome.
All right, thank you, Dr. Natuk. I'm Charles Wong, and I'm a family doctor with emergency training. I work mainly at the Rocky View Hospital, and I'm here to present on my new venture called HomeFree Medically Supervised Home Care. And thank you for Dr. Natuk and the ACFP for having all of us here. We got the opportunity to present our innovations at a forum, and so we were recognized for that, and now we have the opportunity to share with all of you, and we're all very passionate about what we're doing. And thank you also to Dr. Natuk, who was my site director when I was a resident, for not failing me at the time. Honestly, it was a difficult time for me, and I appreciate being here thanks to her. Actually, I gotta say here, the purpose of this, by the way, medically supervised home care, is to solve the ALC crisis. Does anyone know what the ALC crisis is, or are you familiar with that term? Alternate level of care. That's basically patients that can't leave the hospital because they can't get home, and not because they need to be in a hospital. I have to disclose that I'm owner and operator of this medical service. I also have unrelated affiliations to University of Calgary and Alberta Health Services, which are not endorsing me in any way, shape, or form. Also, a slight typo, I'm not a full professor at the U of C, I'm a clinical associate professor. So this is the agenda. I'll skip through this, you'll see what I'm about to talk about. So this is the problem. This is a hospital hallway. This is from a news article. This is my everyday work at the Rocky View Hospital. Basically, patients that are admitted to a hospital who don't even really need to be in a hospital, but they can't get home because of a lack of sufficient home services. Does this sound like a familiar problem to anybody? You've heard of this? And so not only do we have to admit them to the hospital, but in many cases, they can't leave the hospital for the exact same problem. Grandma, 85 years old, had a bummed hip, not even needing surgery, just needed some pain control for a few days, but still can't go up or down a flight of stairs, can't get to the bathroom on her own. Therefore, she has to live forever in a facility. I'm being facetious, obviously, but that's actually not too far from reality. Jumping ahead, in the last year and a half since we've been operating, we've offloaded thousands of these ALC and long-term care bed days from the system by getting these patients home with customized, medically supervised home care. So how do we do this? We looked at the problems that we see. These are not, this was an innovation when we presented it to the innovation showcase, but it's not really that innovative in a way. Everyone knows that these are the problems. Frailty, falls, dementia, failure to thrive, caregiver burnout. They have obvious problems and contributors, but the system, well, the deficiencies, getting regular daily exercise, having a full spectrum of services, not just a medication assist, not just a bath assist, but everything it takes for a family to keep an 85, 90, 100-year-old person at home safely. The physician oversight that's required for some of the medical complexity that we're seeing, it just doesn't exist, and the system doesn't, the system is strained. I'm not trying to be too hard on the system, but the system has recognized these problems for a long time, but isn't able to fill that need. And so the consequence is patients, families, and the system being overwhelmed with caregiving in the hospital where it really doesn't belong. So a couple of facts that I'd like to share with everyone, which I find is actually surprising to a lot of people, because I give a version of this talk to family doctors all over Calgary, and I've done it probably to a couple hundred of family doctors now. But most people don't realize these two facts. One is that public long-term cares are not free to patients. Obviously, they cost our system something, but they're not free to patients. If you're the vast majority of patients that go into a long-term care, you pay a per diem. And on the low end of that per diem is about $70 per day, which is about $500 a week, which is over $2,000 a month. yes, there's means testing, where if you are on AISH or if you're on very, very low income, you can have some portion of this covered. But even if you're an AISH patient or on some sort of government assistance, they'll often deduct part of the per diem from your government checks in order to pay for your long-term care stay. And that starts, by the way, when you become defined as an ALC patient in the hospital, meaning if you're in a hospital and you've been determined to no longer require acute care services, you're now an ALC patient waiting for placement, you start getting billed this $70 a day. So that's the reality that our patients and families are facing. Second fact that people find interesting and is not well understood is that basically all home care is privately delivered home care. So when AHS or Assisted Living Alberta sends people to do medication assist and bath assist in the home, almost 100% of the time it's delivered by one of the big corporate contractors like Bashaw or CBI. And so that is a private delivery of home care, very much like family medicine is publicly funded and privately delivered. But I don't have to tell you guys, most of you guys have heard this already, but this leads to a lot of turnover, different faces coming to the homes and things like that. And that's endemic to this problem, basically from coast to coast. And the link that you see here, if you just Google CBC Marketplace expose on home care, you'll see the video that inspired me to go into this. It's essentially a system-wide, industry-wide problem. And so the flip side of privately delivered home care is that most home care, even when privately delivered, like with our program, can be publicly funded through some novel programs that we have access to here in Alberta. So 3 types of home care: traditional, aka AHS, the regular type of home care, which is what every regional health authority delivers home care by. Private home care is what you Google when you want to do something differently. And then our program we call medically supervised home care, which I'll explain in a second. So traditional home care is actually obviously extremely important. It was developed decades ago to meet a very distinct need: discrete, isolated visits for things like wound care, catheter changes, medication assist, bath assist. When it comes to delivering these really simple, discrete tasks, it does a very good job. It does it at very low cost, and it does it at like a gargantuan scale in Alberta. And so this is where traditional home care helps your patients. If all they truly need is someone to help them bathe once or twice a week, then it's a perfect service. It's especially good for tasks that aren't every single day, because the scheduling is a big problem. So if you just need a one-off OT visit to see if you need a toilet seat raise in your bathroom, or if you need once a month or once every 3 months catheter care, it's really great for that, because people can sit around and wait for that appointment once every few weeks, and that's not a big deal. So this is where traditional home care really shines. But there's a lot of barriers, and I won't harp on this, because if you're a family doctor practicing for any period of time, you'll basically be familiar with these problems. But one of the big ones, and one of the ones that we're trying to solve really directly, is the absence of medical oversight. So if you're a family doctor, which most of you are, you'll be familiar with the random phone call or email from a home care case manager asking you for some random order for something they're trying to accomplish in the home. I've gotten these before. I find them very interesting because it's really interesting what they even need an order for. Like if you need an order to remove a bandage, like what else can you not do without a physician order? Number one. And number two is, like, these things happen and you have basically no idea what's going on in the home. It's like, oh, I didn't even know you were doing that. I didn't know you were there. Great, okay. So the absence of integration is really difficult. So where home care doesn't work in 2026 is complex patients, which is like all our patients. Dementia, failure to thrive, caregiver burnout. These problems just aren't solved by twice-a-day medication assist. They're not solved by twice-a-week bath assists. And this is where families are often found to be burning out and then ending up in hospitals or in facilities. Traditional private home care is the market response to this in the current state. This is where families can pick a provider. This is a really important distinction. When the provider works for the family, they get a very different service, which is very, very good for the most part. The interesting thing about this that's poorly known is that almost anyone can call themselves a home care provider. Like literally every person here, and you guys are doctors, so that kind of makes sense, but I could talk to any room of people and be like, you can all start a home care company right this second, because there's basically no standard that you require in order to start a home care company. And that leaves families in the lurch, because what is a person to choose? Who are they to trust? And we do see a lot of variability in the service that people get, which can sometimes be, frankly, dangerous. And so medically supervised home care is the notion of providing patients with choice of who they want to provide their care, but also overlaying accountability and structure, very much like we're used to in the medical community. So that's physicians overseeing care, but not just overseeing care, owning the care from end to end. So if you're a physician and in our service and you observe in a home visit that a patient who's an insulin-dependent diabetic has a refrigerator that's full of junk food and processed food and not a single thing that's ever been alive at any point in its existence on Earth, then you can make a direct change by advising the home care providers, get fresh groceries from a grocery store and cook them. So that's a big difference, and that solves a lot of the real problems that our patients face. So we operate in a structure that's very similar to a facility: physician, supervision, and ownership, overseeing nurses and healthcare aides that deliver service in the homes, and then we deliver it in a way that's publicly funded, and in most cases actually more affordable than going to a public long-term care center for the patients, never mind the system. And so the problems that we identified previously with traditional home care we try to meet, things like language matching, English being the most important language to match, which is surprisingly difficult to do in the rest of the industry we find, but also other languages like French, Chinese, and then the physician aspect of it, of course, which is the in-home services for medical nursing, treatments, imaging, et cetera. So how are we solving the ALC crisis? This is really interesting. So I don't know if you can see this super well, but essentially the y-axis is medical complexity. There's patients at the top of the axis which clearly require hospital admission. They require advanced interventions, surgery, et cetera. There's patients that clearly don't. They're at the bottom of the scale. And there's all these people in the middle, which is we have this negotiation with them and their family as to like, okay, can you or can you not go home based on what your social supports are in their current state, what the family can do, in other words. And it's really surprising, and this happens in the ER, but it also happens on the ward. And I've been doing this for a decade. My wife's a hospitalist, and it's just, and I'm not trying to be too critical of anyone because this is a system problem. Like the system's full of really hardworking, well-meaning people, but in the system, it's shocking how little effort is really put into determining that a patient is long-term care bound. Oh, you can't walk up and down the stairs? Okay, well, long-term care for you. Oh, you can't get to the bathroom? Long-term care. That's, I mean, I'm not being that facetious right now. This is literally what families tell us on a regular basis when we're getting them out of the hospital. And so a healthcare team in the hospital says, okay, you can't go up and down the stairs. Our solution is twice a day med assist and a bath assist. That doesn't help you go up and down the stairs, therefore your long-term care. And so that's what the sideways or diagonal triangle is about. Like, we're trying to bring their needs down, but we're doing it in a way that actually doesn't help patients because the solution's not customized to their actual need. And so they're misdirected resources. And we hear from families all the time that not only are the resources not helpful even when they accept them, but sometimes they actually make things worse. And so medically supervised home care is about doing whatever it takes to get people home. This could mean nighttime care for families that have a patient that wanders. This could mean daily exercise for people that are frail and fragile and recurrently fall and don't get enough exercise even in the rehab facilities. It could mean what I said earlier, which is putting the proper food in their fridge so they don't keep representing with hyperglycemia or DKA. And so it doesn't take a lot. Sometimes it just takes a little bit of customized care to get them below that line of thriving at home continuously. And we do this with the existing public funding arrangement that pre-existed our company, which is the AHS CDHCI program. Has anyone heard of this program, by the way? It's a really excellent program. It's very difficult to get. It's an AHS program. Don't ask me why, but AHS makes it very difficult for patients to access it. I don't think it's deliberate. I just think it's not very aggressively administered. And so it pays a certain rate, which covers most of our costs and most costs for most private home care providers. And patients get to pick their own providers, and then they can ascribe their hours to a provider rather than to AHS Home Care. And so to get this, if you're a family doctor with a clinic and you want your patients to get private home care that's publicly funded, make sure you assign this task to the most responsible daughter, because that's how things are gonna get done. And I was literally talking to a family recently, like at a Care West facility. There was a dad there who's trying to get out, and there's two sons, and I'm explaining to them the CDHCI process, and then one son looks at the other son and says, "Your wife would be really good at this." That literally happened this week. Okay, so anyways, outcomes range from 0 to 40 hours. Your average dementia patient who, let's say they don't need like a locked ward, but they need assisted living, that person often in our experience qualifies for anything between 15 to 25 hours a week of publicly funded home care. That equates to like four hours a day almost of one-to-one support. That's life-changing support for a family. It's very different than AHS Home Care, and it's available to them if you help push them through the finish line. So I'm just going to end with this. This is shared with permission from our patient, Merdine. She went into a hospital for an elective surgery, hysterectomy. She developed weakness, and that weakness got worse as she was in hospital because she was basically bedbound for 23 and a half hours a day, went to a Care West facility to rehabilitate. She only got worse and worse. She was destined for long-term care. We brought her home with 24-hour supports initially, and then gradually weaned her off, and now she's walking around independently at her home. This is not a unique scenario. We did this for dozens of patients last year. We've saved the system, I think, thousands of long-term care and acute care bed days. In my view, it's very simple. It's very difficult to do, but it's very simple, and I think that we should expand on this program as much as possible. And so this is what we're doing: medically supervised home care, keeping patients thriving at home when institutionalization might otherwise be necessary. It is a very efficient solution for our system's perhaps biggest problem, which is ALC or bed block. And currently we're only in Calgary, but we're hoping to expand to Edmonton next year, and I'd be happy to chat with anyone about it by email or in person if you guys are interested. Thank you for your time.
Hi, my name is Georgina Gaudet. I'm a community volunteer and health system transformation lead with the Bashaw Medical Clinic. Just in terms of disclosures, this is nice and easy for me. I'm a community volunteer, so being remunerated only for expenses in coming to today's session. First off, I just wanted to thank you all for having me here today and allowing me the opportunity to join my fellow innovators. We pitched our idea, Dragon's Den style, to ACFP's Innovation Forum in the fall, and more importantly, networked and dialogued with many of you and your peers at that forum. I'm excited to be back to share our community's primary care model with all of you today. It's an innovative partnership between Sylvan Family Health Center, Bashaw Medical Clinic, and Bashaw and District Support Services. This collaborative approach is one that our community is deeply proud of. We see it as a practical, scalable solution for delivering sustainable primary care to patients in rural communities. And so my story begins the way all good superhero tales do. As hope for rural primary care began to fade, the Bashaw region came together to chart a new course. We forged a bold idea, an interdisciplinary, team-based model of care. We call it the Vital Alliance. Heroes united in a mission to strengthen rural health, champion wellness, and put patients first. Well, I'm not going to weave the entire superhero theme into today's presentation, but I did want the opportunity to mention that I brought along some of our limited edition Vital Alliance superhero trading cards with me, and if anybody is interested in learning more about our superheroes on the team, I'd love to chat with you at lunch. So like so many rural communities across the province, the Bashaw region had 30 years experience accustomed to a common pattern. Physicians were attracted and recruited to our rural community's primary care practices. Patients were expertly cared for and served by their primary care provider with professionalism and dedication. But with the many demands on a family physician's time and expertise, coupled with the well-documented challenges of rural practice, rural medical clinics like our own often experienced a recurring pattern of turnover. This presents a challenge for rural patients and volunteer organizations who undertake these recruiting roles, a difficulty in sustained continuity. So when Bashaw's lone family physician announced his plans for retirement, he gave our community the gift of time. Instead of tackling the challenges of attraction and recruitment from a place of panic or exhaustion from having undertaken the process just a few years before, our team of primary care recruitment volunteers were gifted the opportunity to be thoughtful in our next steps. We approached the challenge with curiosity. We asked the question, what were primary care providers looking for in a rural practice? This is what we heard. Complex rural patient panels are an almost guaranteed path to burnout for a sole practitioner. Owning and operating a rural clinic in an unfamiliar community is financially risky and expensive. Rural physicians prefer practice diversity, pairing their work in primary care practices with shifts in other essential settings like hospitals, urgent care centers, and emergency departments. This was a big eye-opener for me, just how busy you all are. And finally, many physicians favor team-based models to reduce isolation and share responsibility for practices based in rural Alberta communities. Around the time that our community undertook this work, the Modernizing Alberta's Primary Care System, or MAPS report, was released, which validated both our observations and reinforced a shared common experience for rural communities across Alberta. Which leads me to the second half of our inquiry, that is our rural communities' experience with primary care. We found that many patients were choosing not to seek care from a regular family physician or nurse practitioner and instead used walk-in clinics or ERs for their care needs. Of course, as you all know, this results in fragmented care, poorer health outcomes, and ultimately patient dissatisfaction with the healthcare system as a whole. So in response to our assessment of our region's primary care situation, we decided to explore a different solution to our physician attraction conundrum. We decided to explore, we asked, what if we could create conditions where physicians could just bring their stethoscopes and practice? What if we designed a rural workplace that supports rural primary care practitioners and in turn better supports rural patients? So our first step, we transformed the Bashaw Medical Clinic into a community-owned practice, enabled through community fundraising efforts and MAPS grant funding. At the Bashaw Medical Clinic, physicians don't have to worry about sourcing a rural internet provider or outfitting their practice with all the basic necessities. We understand that when the community supports the clinic can focus on caring for the community. As part of this support, we assembled an interdisciplinary primary care team of local healthcare providers. These folks live, work, and raise their families in the Bashaw region, which makes it a lot easier on the community in terms of recruiting for these roles. We discovered there were many interested healthcare professionals who wanted to work closer to home and in primary care, but just didn't have job opportunities that allowed them to do so. Each member of our interdisciplinary team is empowered to work to their full scope and encouraged to collaborate in order to forge bold new pathways for primary care. To give you a sense of their clinical contributions at the Bashaw Medical Clinic, our clinic's nurses manage chronic diseases, minor ailments, and preventative screenings. They also are focused on supporting patients with timely, accessible appointments. We have 2 part-time RNs, and both are enrolled in Athabasca University's RN prescribing program to further expand upon their scopes of practice. Our advanced primary care pharmacist participated in the National Team Primary Care Initiative and has completed training in comprehensive primary care delivery, including in the areas of physical assessment and mental health. He's an independent prescriber and supports our nursing team and working in close partnership with our physicians. He provides comprehensive longitudinal care to a predominantly complex and elderly patient population. He also leads weekly patient rounds at the assisted living facility in Bashaw, providing continuity for home care nurses, lodge facility staff, patients and their families with collaborative physician oversight. And the cherry on top of all of this, a formal partnership with the Bashaw and District Support Services ensures that Bashaw Medical Clinic delivers coordinated wraparound services for patients. Physicians and the local interdisciplinary team can focus on medical needs, while community and social services partners lead on broader social determinants. This really helps us get at the rural patient complexity barrier that many rural practices face. When a patient presents to the clinic with significant socioeconomic challenges that extend beyond the traditional scope of clinic-based care, patients are given the opportunity to invite community resource navigators into their circle of care. The navigators connect these patients with the broader integrated health neighborhood of services and programs that are available to them. This shared care approach reduces unnecessary clinic visits, improves continuity, and ensures patients receive the right support from the right provider at the right time. Our innovation attracted 6 physicians from the Sylvan Family Health Center who aligned with our vision and committed to supporting care delivery in the Bashaw region. Through our shared service model, participating physicians provide a combined total of 2 to 3 in-person clinic days per week at the Bashaw Medical Clinic, while also maintaining their commitments to their other diverse practice settings like urgent care, hospitals, and other long-term care facilities, just to name a few. Our physicians are really busy, So they travel to Bashaw for in-person appointments on a rotating basis, with some physicians coming once per month and others up to 4 times per month, for a total average of about 0.4 FTE in in-person physician time at the Bashaw Clinic. When they are not physically at the clinic, our physicians are available to patients and the local interdisciplinary team virtually. Together, the team cares for a panel of 1,500 area residents. I'm very confident in this number because we also have accumulated a waiting list. And to address this, we have plans to extend care to more patients this spring. For the Bashaw Medical Clinic, our physician partners are our North Star. They are the clinical leaders and anchors of our integrated model. The strength of the clinic is rooted in the trusted, collaborative relationships they have cultivated with our local interdisciplinary team. Relationships that support seamless coordination, shared accountability, and consistently high quality care for our community. Our innovative approach also enables consistent access to care Monday through Friday, 9 to 5, with select evening hours to better meet patient needs. I just wanted to point this out because it is a dramatic access improvement for the clinic, as it was open 2 days per week and served a panel of about 500 patients previously. Our team-based care approach has expanded hours of operation and tripled baseline panel size since we implemented this model of care just 1 year ago. And do our physicians like working at the clinic? Well, they talk about the refreshing change of pace and the rewarding interactions with their Bashaw panel. When physicians take a vacation or time away from the practice, they have confidence knowing their patients are well supported by the rest of the team. And if, heaven forbid, any of our physicians move on from the clinic to care for patients elsewhere, the Bashaw Region's panel of patients will continue to be served by the remaining team, allowing us, again, the precious gift of time for thoughtful, coordinated recruiting efforts. Woo. The Bashaw Medical Clinic is proof that rural communities can co-design their own care. Our region didn't fix our challenges by recruiting harder. We fixed them by redesigning the model. We aligned physicians, local leaders, and services around a shared vision for primary care. Our story demonstrates that rural communities can be architects of their own models of care, and if it works in Bashaw, it can work anywhere communities are willing to lead, partner, and innovate. Thank you.
Hi everyone, I'm Shani Kara. I'm a family physician here in Edmonton, and I wanted to first thank you all for this opportunity for me to share our innovation story and how my colleague there, Dr. Marjane Abbasi, and I created a health technology that really helps us support, enable, and operationalize team-based care in the primary care setting. For disclosures, I do want to let you know that I am one of the co-founders alongside Dr. Marjane Abbasi of CARMi Health. During this journey, we did end up creating our own company, and I'll explain to you why that was. And also, we received some grant funding from the Department of Family Medicine to do some of our evaluation around what we've been doing. So to starters, I actually just want to say this out loud, is we didn't actually set out to create an AI tool. We actually set out to address a clinical challenge that we were living, and that had to do with care of older adults and their family members that are living with complex health needs in the community. So Marjane and I are actually longtime friends, and we were at a coffee shop together back in sort of tail end of 2015, start of 2016. And she was sharing with me this model of fitness to frailty, and you see it right there. And oftentimes we were actually letting families and patients go through all these changes literally on their own, bouncing back from emergency departments, being admitted to hospital and sent out. And then Marjane was only able to see them in her setting at the geriatric assessment unit or in acute care when they were already further along and in the moderate to severely frail stages. And even though her team was amazing and they were able to provide some really useful interventions, it really was kind of quite late. And that was very morally distressing. And so when she came to chat with me, we both sort of sat there and said, you know what? We do our work in primary care. Can we do something different? Can we create a preventative, proactive model? Maybe jump in earlier when that person is showing some early signs of vulnerability, or bolster their caregivers and themselves and really make a larger difference. When we think about the primary care setting, as I was reflecting, that very busy picture there is what I was thinking. I was like, oh my goodness, like right now, I barely have enough time the way that the structure is set up for me to take care of the knee pain, even though I really want to have the opportunity to uncover other things going on in that senior's life. In addition to that, if I do open Pandora's box and ask more questions, then who is there to support me? I didn't really know then who would help navigate and do other things that are not in my scope of expertise. It was around this time, actually, that my clinic had joined the Edmonton O'Damon Primary Care Network. And I had a team available to me, but I didn't know how to quite leverage them. So we took all these factors together, and while we were sitting there at that Second Cup coffee shop right across the street from the Misericordia Hospital, we kind of started jotting out a seniors program. Could we use the already invested people that were in the PCN and really do something different and dramatic here? And so we did. With the amazing help from O'Damon, we had access to pharmacists, chronic disease management nurses, we had dietary support, kinesiology support, and we created an integrated primary care model to optimize seniors' care, where we would actually have conversations earlier on and talk about, health literacy and other things. The model was a huge success. We actually won a Canadian Frailty Network Award in 2018 for the best innovation across Canada. And we had a whole evaluation framework around this, and we made some significant impacts. We actually improved people's quality of life, improved caregiver burden, helped offload some of their stress. We improved the health literacy that I was talking about regarding healthy aging. We improved mood, quality of life, pain, mobility, and medication appropriateness. So when we went talking to others outside of our province where we have PCNs, they'd say, that sounds really great, but I don't have access to those people that you're talking about. Or rural communities would say, you know what, we have way more challenges than maybe even what you guys are mentioning in your areas as well, and we don't have access to these teams, or they're not co-located, or lots of other things. So we decided to go back to the drawing board. So we knew that the model worked. The problem was actually scale. How do we take it and give it in the hands of everybody? And we were missing one more care team member, and that was technology. So we went to the drawing board again, and we thought to ourselves, our experience and the evidence tells us that people who have complex care deserve these 3 T's. They deserve the time, first, for a very thorough assessment that standardizes and covers not just their medical issues, but their whole health context. They need teams. They need more people than just their family doctor to help support their care, to uncover those things, and to help them manage them. And we need the proper tools, which we're often lacking. And a lot of clinics we went to are actually still using paper-based assessments, writing it all out, then inputting it into their EMRs. EMRs don't let more than one person really jump in to do collaborative care. So we were missing that tools piece, and that's what we went out to create. So again, innovation pivot. We actually went talking to others as doctors. We're like, we're not, technology people, and I'm like the least techie person you'll ever meet. And yet here I've created this. And so we went talking to other companies and other people, but we found quickly as clinicians, they tap us on the head and say, good job, guys. That's a great idea. And they were having conversations on the side without us. And the vision was being altered than what we were really wanting it to be. So we decided to create our own company and have an equal seat at the table. We bootstrapped a small team. It's just Marjane and myself as co-founders. We hired a developer. We hired a UX designer who can help us make sure that the platform was easy to use and friendly, because we have patients on there and caregivers along with healthcare team members. And we have a privacy and regulatory lead, because that's very important to us. And we wanted to make that privacy built right into the architecture, so privacy by design. We joined a number of accelerators. Here at the U of A, we have some. In Calgary, they have them as well. We joined IMEAG, Plug and Play, and several more to increase our knowledge of what does it take to do what we want to do here. And in June 2024, we actually launched our AI-powered cloud-based platform called CARMi. And again, not as a startup experiment, but really as the infrastructure to permit us to scale this proven primary care model. So what is CARMi? I think it's pretty neat. So it is actually completely cloud-based. And on this platform, you can invite all different team members. So they can hop right onto the platform. Patients and families can hop right on there as well. It meets all privacy requirements, as I mentioned. And now you can work through a shared assessment, a standardized shared assessment. So it builds decreases duplication, and builds team visibility. And it's, as I said, it's multi-domain for geriatrics, but we can do other chronic conditions as well. We built in some clinical guidance, risk flags, care tips. We have community resources, and this is where we're leveraging our AI, and I'll talk about that in a minute. So, and then with that one assessment, you can create multiple outputs. So now you're picking and choosing the high yield sections that you want to create and send elsewhere. So very different, as our earlier presenter mentioned, of getting a booklet of all this content. Here you can really customize that. So in a CARMi enhanced flow, you have removal of all that administrative burden and the cognitive burden of finding all the resources and getting all the healthcare tips. It's all built in there right for you at the point of care. I want to talk briefly about responsible AI. I want to shift our thinking. It's good to be skeptical about AI, but let's not be scared. And in fact, I want to shift it to let's be skilled. When we talk about human in the loop, I think when it comes to health technology, it needs to be clinicians in the loop. We know how we think, we know the workflow, and we need to be the ones that are guiding and shaping this. In our system, the AI is used in a very deliberate way. We use it to do all of the summarizations. It's like nearly 100%. We've now added AI Insight where we feed it the content that we think is most valuable. So it's not picking up random things from the large language model out there. So it's been really very deliberate as a support for my decision making, not to decide for me, but to support me in my decision making. So early signals of success and what we've been able to achieve here. So we've been able to, on the access and efficiency side, decrease 60 minutes of time that right now our teams are actually doing on like typing everything up after seeing a patient. Quality of care. So we have had some users of CARMi say now that we have it this way, the documentation is so clear, we've actually been able to meet accreditation standards. We've been able to shift the workflow. So there used to be, nurses that'd be on the phone calling back and forth to patients to do an assessment with them. And now we actually have a navigator that takes on that role. And the navigator is the most appropriate person also, because now you can direct them to other resources, or other things that the family can start doing as well. And you kind of get rid of that concept of wait time. When you're always waiting for that one big assessment that's 3 hours, you put a lot of emphasis on that. And here, by doing it asynchronously, you can actually kickstart the care much, much earlier. And also, we've been able to, the sites that we've gone and implemented have sustained that use of CARMi. So that's been really very validating for us. For system alignment and equity, I just wanted to let you know as well, because it's now standardized and we are exploring social determinants of health, more people are actually getting access to good care. We're helping aging in place strategies, workforce sustainability, because as they can see the tools and the resources, it's actually building the team's competency and comfort also in chronic disease management. So it's been really very exciting path. So key lessons. Really think about what's going on in your life and your practice and where those pain points is. That's where the innovation is going to come from. Map real workflows. Structure creates that capacity. Redesign the teams and invest that time to really kind of know who's doing what, and is that the right person to be doing it? Or could that be allocated to our other team member, AI or digital tech? Evaluate before scaling, and AI really must function as a team member, not as a replacement. The last thing I want to say is, as we move into this digital world, if we really want digital tools to reflect family medicine values, then we really need to be at the design table. Thank you.
Thank you so much to all three of you. I find your work so inspiring. It's wonderful to see the innovation that happens in family medicine and in the community. So we have time for a couple of questions before lunch. So if you do have questions in the room, please make your way to the microphones. We can start right here.
Hi, this question's for Dr. Wong. Is it just in Calgary, your service right now? Can we refer from a community setting? And what about people that have no POA and are stuck at home? Can they access you?
Thank you. Can I just clarify, people with no QA?
Sorry, I have a patient with no POA. She needs to be in a home, and she's stuck at home with no care.
If someone doesn't have a POA, just to address that, I guess they would be their own decision maker and we can help those people for sure.
She's not a decision maker. She's been ruled incompetent.
If that's so, I'm not.
Yes, so that's why I'm thinking, can you help her?
Maybe the easier question is, we are only in Calgary right now, sadly.
I'm in Calgary.
But we hope to expand to other municipalities. And for complex decision things, we do consult lawyers for that sort of thing. I'm not an expert in that, so we would definitely want to work through that with you to make sure because as a business entity, we can't help patients endorse our services. We would have to use a third party.
Okay, so can we refer, if we're in Calgary, to you from a community?
Absolutely, yes. Fax Alethea, or you can come find me after this.
Awesome.
Thank you.
Thank you. I have one from an online question, and we'll go to Dinesh after that. For Shani, does CARMi accommodate other languages, especially for families and caregivers?
So we have a very exciting roadmap, and that is something that we plan to build in. At the moment, it's just for English speaking right now, just because, again, we're doing the evaluation pieces. But 100%, when we think about access, language needs to be considered for sure.
Thank you. And then Dinesh. No. Do you want to come up here, Dinesh?
Yeah, I wore my jogging suit for this. My question's for Georgina. So it sounds like the community came up with a lot of the resources, like manpower, volunteer work, and financial to make this come together. One of my passions is how to make family medicine, comprehensive family medicine, more sustainable, especially if people who are supposed to fund it aren't funding it. How do we kind of look at other options? So who did fund this, and are they a nonprofit? Did they get charitable receipts to the donors? Are those mechanisms that other clinics could look at as a way of helping support their practices?
Yeah, good question. So we were the recipients of 2 MAPS grants. So for the clinic recruitment, so all the clinical staff, that was one MAPS grant, and then the other was for creation of the clinic, so the administrative component, I guess. And they are matching dollars grants, so 2-year matching, dollar for dollar matching. So that BDSS organization that I mentioned, Bashaw District Support Services, is a nonprofit. It's the local community and support services program for Bashaw. And so yes, they can write tax receipts for people donating for those matching dollars that we're trying to raise. However, I also have to say that I agree with you. I think funding needs to be sustainable for primary care. If we're wading into these primary care teams, we need sustainable funding for the teams as well. And I just finished a roadshow with our local municipal leaders to just provide them with the information that they need about the clinic, and maybe a lot of them are raising their voices to just ensure that provincial decision makers also know that this is a provincial responsibility to fund healthcare.
Thanks so much, everyone. Unfortunately, we've run out of time to answer any more questions, but I'm sure for those of you who are in the room, if you have questions for our innovators, they'd be happy to answer them here. Otherwise, it's time for a lunch break. So we'll encourage everyone to go and grab some lunch, and then we'll be back here together at 1:30 sharp. Thank you.